Thank you for your time this afternoon. I'd like to welcome you to our presentation. It's brought to you by the Boston Custom Lab channel of Bausch & Lomb. Today what we're going to talk about is irregular corneas and which lens option is right for each patient. For those of you that don't know me, my name is Lynette Johns. I'm an optometrist and I serve as an adjunct assistant professor in the Department of Specialty and Advanced Care at the New England College of Optometry. I also see patients and am a clinical attending in the Department of Contact Lenses at the New England Eye Institute. I also serve as a paid clinical and education consultant to the Bausch & Lomb Custom Lab channel that's sponsoring this presentation today. So what we're going to talk about today is basically we're going to define the irregular cornea and give some examples of the different types of conditions of these types of patients. We're going to describe the different contact lens options and contact lens modalities that help you fit the irregular cornea. Oftentimes, the first thing we think of with irregular corneas is Corneal GP lenses, or an RGP lens to correct these irregular astigmatism patients. But there's a whole variety of different lens options that are available to you, especially if you're intimidated by trying to visually rehabilitate these patients when you first see them, especially if you haven't had much experience or exposure to patients with these types of conditions. We will describe fitting tips for each lens type and modality. And we're also going to explore just different clinical decision-making for the patients, not only with the lens modalities and like the fitting strategies, but also big picture ideas, like how their lifestyle plays into what type of modality we're going to use, if there's other concomitant ocular physiology issues or ocular health issues or ocular diseases. I'm going to describe some patient scenarios that would actually kind of be a real-world situation of how I would strategize using one lens modality over another. And lastly, I'm going to describe some of the clinical education resources that the Bausch & Lomb has to offer you to help you fitting your patients. So let's get started in talking about the irregular cornea and the patients that present with these. So first, we have the naturally occurring ectasias. So it's kind of like the triad. You've got keratoconus, pellucid marginal degeneration, and keratoglobus. Now, these may be described as distinct entities, but in my clinical experience, I often find these more of a spectrum, and they kind of tend to overlap. So keratoconus itself is a condition that begins, the onset is usually puberty, and it's a self-limiting condition, so it's progressive, but eventually stops to progress in most cases in the late 30s, 40s, or 50s. Then you have pellucid marginal degeneration, whose onset is usually in the 4th to 5th decades, and that can continue to progress. And lastly, there's keratoglobus. And keratoglobus is often a congenital condition, but there are acute cases that can be progressive in some situations. Here's an example of corneal topographies and OCT profiles of each of those naturally occurring ectasias. On the far left, you see a typical with the rule normal cornea. And now keratoconus has got many different subcategories, especially when you're talking about the ectasia portion or the bulge portion of the cornea. You can have different shapes, different locations, different extents. So the topography shows a decentered nipple cone up top, and here on the bottom you can actually see what the typical profile of this type of keratoconus would look like. Now I'm going to contrast that with pellucid marginal degeneration. Here you can see that the stromal thinning is actually occurring at the same location of the apex of the cone. However, when we're talking about pellucid, we have the thinning that is occurring inferior to the ectasia or the bulge. And often pellucid will have the thinning occur between the 4 and 8 o'clock location in the mid-peripheral cornea. That's where the cornea thins the most. However, pellucid marginal degeneration is a degeneration that is peripheral. So this can also happen, albeit rarely, superiorly in the cornea as well. And lastly, we have keratoglobus. And keratoglobus demonstrates a very thin cornea throughout, and the cornea does protrude all the way throughout, as you can see here. And often the thinnest portion is actually the mid-peripheral portion as well. But here you can also see where if you had a very large cone, it could be easily confused with keratoglobus. Now that's the naturally occurring ectasias. Then we have irregular corneas that happen as a result of that either are treated surgically and still have irregularity to them, or are a result of surgical treatments. For instance, post-LASIK ectasia, where there's ectasia or a bulging, thinning and bulging happening after the LASIK procedure was performed. There's radial keratotomy. And then treatments for irregular corneas are intrastromal corneal ring implants, there's corneal collagen cross-linking, and penetrating keratoplasty. Now, penetrating keratoplasty we always think of as an endpoint for keratoconus, but it can also be a treatment for Fuchs corneal dystrophy. So if there's a bullae that's forming as a result of edema, a corneal transplant is indicated. And that can result, even though it's a treatment for irregular astigmatism, it can also result in irregular astigmatism. Here's examples of different types of RK procedures. You can see the unfortunate picture on the left where the incision went straight through the visual axis, and there's some hemosiderin deposition inside that incision mark, so there's some scarring there too, as well as you can see the numerous amounts of incisional cuts that were made on the picture on the right. So these poor patients are suffering from significant visual disturbances as a result of their refractive surgery procedure done years ago. Here's examples of topographies of post-LASIK ectasia. You can see this inferior steepening. A lot of times when I have seen it presented to me, it almost looks similar to a pellucid marginal degeneration case. Now, thankfully, because of intense screening procedures done in LASIK centers worldwide, the incidence of post-LASIK ectasia has definitely dropped significantly. But in those early cases of LASIK, where there might have been a form frused keratoconus patient that was operated on, it may result in this type of presentation after the surgery. And in some cases, it is self-limited. In some cases, the ectasia continues to progress. Here we have intrastromal corneal ring implants. You can see that these are sometimes called intacs. You can see these implants in the cornea. Now, this is a rare situation where there was actually an inflammatory response to the surgical procedure. However, this can be an effective treatment for flattening the cornea to help with contact lens fitting or contact lens tolerance. So some of our patients that have irregular corneas may have underwent this procedure. Lastly, here's just a typical penetrating keratoplasty where you can actually see the host and graft junction here, and you can also imagine that this graft is coming forward or coming at you. So there is some depth to this cornea that's creating this irregularity for this patient. So let's talk about 3 categories of contact lens options. Now, there's a few other categories that kind of overlap in there, but I'm really going to focus on these categories today. There's soft lenses, there's corneal GP lenses, and there's scleral lenses. In addition to these categories, we kind of have the overlap. So we have the hybrid lens that has a rigid center and a soft skirt. And we also have a piggyback or tandem lens option where a soft lens is placed underneath a Corneal GP lens. So let's begin by talking about soft lenses for irregular corneas. Soft toric lens options soft toric lenses are an option for patients, and these are just the regular disposable soft torics off the shelf in those early or mild cases of keratoconus or mild corneal irregularities. Your patients will likely be successful with a soft toric contact lens option if they're able to be effectively corrected with glasses or spectacles. Now there's specialty soft toric contact lenses that are lathed custom toric lenses that can expand the cylinder powers for you, especially in these patients that have irregular corneas. They may have higher levels of astigmatism, and while it may be irregular astigmatism, you might be able to still effectively correct them to functional visual acuity levels just with a regular toric option. And lastly, in the soft lens category, there's specialty soft contact lenses that are made specifically for irregular corneas. And there's basically two realms of this. Now, as an irregular cornea lens fitter, oftentimes our first thought on fitting irregular corneas is fitting a Corneal GP lens, which we're going to cover next. But when we think about fitting the Corneal GP, we're mainly employing that rigid center of the rigid surface of the lens and filling the back surface of the lens with a tear film or a lacrimal lens that basically masks and neutralizes the irregularity or the irregular astigmatism that the patient has. It effectively becomes one optical system. The lens, the rigid lens, the tear lens, and the irregular cornea become one. So in the traditional custom soft lenses for irregular corneas, they actually have employed using increased center thicknesses in order to create a little bit more rigidity to have that masking benefit. So there's a variety of soft custom lens options on the market that employ increasing center thicknesses in order to effectively mask the irregularity. Now Bausch & Lomb has a different type of lens, and it is called the Kerasoft IC lens. And basically this design is patented and drapes over the cornea. And the advantage of all custom soft lenses for irregular corneas is that the optics remain centered. But in the Kerasoft IC lens, they don't use changes in center thickness to mask the irregularity. All the Kerasoft IC lenses have a balanced overall thickness. They use relatively flat base curves. It incorporates a diagnostic fitting set. They use front surface aberration control optics in order to correct the irregularity. So often you'll find high cylindrical corrections using this particular lens modality. The other features of this lens is that it has a modifiable periphery, whether it's steep or flat relative to the base curve. It also has two sectors of independently modifiable peripheries. So in those cases where you have, say, a transplant where the soft lens tends to have edge standoff in one position, you can actually tuck that edge down and designate where that location goes because this lens is prism ballasted. There's extensive training available on the website for this lens modality. So the Kerasoft IC does have an 8-lens trial set, and you can see the fitting parameters here. And how you fit it is using what's called a dynamic assessment fitting technique. And they use the acronym called Morocco VA. So Morocco stands for movement, rotation, centration, comfort, and visual acuity. So movement, there's up to 2 millimeters of movement. Rotation, no more than 10 degrees. Usually you want as little rotation as possible. They should be well-centered. It's a soft lens, so it should be comfortable, and the vision should be stable between the blinks. So if you're interested in learning more about this lens available through Bausch & Lomb, you can visit the kerasoftraining.com website. So now we're going to switch gears from the custom soft category to Corneal GP lenses. So like I said before, Corneal GP lenses employ rigid lens materials. So while we call them GP, we've eliminated rigid from the name, mainly for aesthetics to a patient, so it doesn't sound so intimidating. The lens is a rigid lens, and it has to be in order to mask the irregularity. It incorporates gas-permeable materials, so while the lens is rigid, it's breathable. And there's some great lens materials that are available with high decays that allow adequate levels of oxygen to reach the cornea so that the corneal physiology is not impaired. It masks the irregularity by incorporating a tear film underneath the lens. And it requires tear exchange not only to maintain ocular physiology but also to bring oxygen in. And also, just like the specialty soft custom lenses, they also require diagnostic fittings. It's really helpful to have a diagnostic set. It's a very effective visual rehabilitation option. However, one of the disadvantages that we all know of is that adaptation can be problematic with this lens modality. So let's talk about the fitting flow. First, what you want to do is you want to evaluate the corneal topography of your patient. And sometimes you may not have access to a corneal topographer, so sometimes it's actually helpful to use a Corneal GP lens to act as your topographer, because you can see the pattern of the irregularity using the fluorescein pattern. But if you have a topographer, it makes it a lot easier. You want to determine whether the shape is nipple, oval, or globus if it's keratoconus. You want to determine the severity level of it. Is it mild, moderate, or severe? And here, just to delineate what mild, moderate, and severe, I'm using the CLEC study classification. For those of you that aren't familiar with CLEC, CLEC is the Collaborative Longitudinal Evaluation of Keratoconus Study, and it was a very intensive study that is very well published on keratoconus, and how they define mild, moderate, and severe keratoconus is using the steep K. If the steep K is less than 45, it's mild. Between 45 and 52, it's moderate, and greater than 52 is considered advanced keratoconus. And lastly, you want to determine if your irregularity is centered or decentered, because that also plays into how you're going to fit this lens. So once you've determined what shape you have, you want to designate which overall diameter you're going to select. You determine your base curve, and then you evaluate your fluorescein pattern. So let's talk about diameter selection. This is why it's really helpful to know what type of irregularity you're working with. So here we have an example of a nipple cone. And so for mild nipple cones, you basically want to start with more of a larger lens, so 9.6. But as the cone severity becomes more advanced, you're going to decrease your optic zone and decrease your overall diameter as the severity increases. And the reason you're doing that is because these nipple cones tend to be quite focal. So what you have to do is your ultimate goal is alignment on the cornea. And so this is creating a pretty big obstacle to align. So you want to basically center your optic zone around the cone itself, and then align the mid-peripheral cornea and the peripheral cornea as best you can with your diameter. Now conversely, if you have oval or globus cones, you start with a smaller diameter, and here we say 8.5, but in fact it could be a 9.6 like in the other example, but you start to increase your diameter if the severity or the steepness advances. So here you can see the diameter can go up towards 11.2, which is considered an intralimbal corneal GP lens. So once you've selected your diameter for this patient, then you want to look at the base curve. And how I would go about it is just check with your trial set manufacturer and abide by the trial set recommendations. These labs have done a lot of work and homework behind their particular designs, so they in fact have some really good recommendations to start with. Otherwise, you can start with average K. If you begin with average K, you're likely going to start a little too flat. So you'll see some apical bearing, and eventually you're going to start to fit steeper until the first definite apical clearance, or FIDACL, from the CLEC study. An alternative way is to start with the steep K. If you fit on steep K, then the lens will likely pool over the apex, so you'll have apical clearance, and you'll successively flatten the curves until the first lens begins to feather touch that apex. So this is a strategy for base curve selection. Let's talk about fluorescein patterns. There's three basic fitting philosophies. First, there's the flat fitting philosophy, as you can see on the top right. A misconception of fitting flat is that some people suspected that by fitting flat it would slow or halt the progression of keratoconus. In fact, that doesn't happen. Unfortunately, by fitting flat, you will end up increasing the risk for patients to develop corneal scarring. So it's very, it can be very compromising to the ocular physiology. But one of the benefits of fitting flat is that the patient may achieve improved quality of vision. Now there's a steep fitting philosophy. So the advantage is you're protecting the corneal apex. So you're protecting that apex against mechanical contact. The disadvantage is that it's prone to peripheral seal-off or adhesion and bubbles. And here you can actually see a bubble forming under this lens. Now, what I'd like to highlight is in the CLEC study, approximately 75% of the patients, and there was thousands of patients that were in the CLEC study, 75% were actually successfully fit with corneal GP lenses. Now, of that 75% of GP wearers, 87% had a flat-fitting GP lens, and after 8 years, 31% of them went on to develop corneal scars. But only 9% of those patients that had steeper fits went on to develop corneal scars. So this is kind of indicative of how important it is to respect the apex of the cornea. So the third fitting philosophy that seems to be most commonly accepted is the three-point touch fitting philosophy. And basically that's balanced touch of the apex and two mid-peripheral areas along the same axis. So here you can see there's some feather touch of the apex of this cornea, and if we go along this meridian right here, there's touch here, touch here, touch here. So three-point touch. And what this allows the lens to do is evenly distribute the weight of the plastic of this lens. And in general, it's thought to be the safest for long-term corneal health. So now we're going to switch gears to scleral lenses. Scleral lenses are large diameter GP lenses. So they're made out of the same materials as the corneal lenses. They follow the same optical rules as the corneal lenses, where they mask the irregularity, but instead of a tear film, you're actually filling the lens with preservative-free saline solution or preservative-free artificial tears. Now, there's scleral lenses vault over the irregular cornea. Now, I put a little asterisk here. Some lenses are called corneal sclerals, and this category will actually balance the weight on the cornea and on the sclera. So in some cases there is corneal contact. But for most of this presentation, when I refer to scleral lenses, I'll be referring to lenses that vault over the irregular cornea. Now the reason they're called scleral lenses is because they actually rest on the sclera, which is kind of not true because they're resting on the conjunctiva overlying the sclera, but nonetheless the majority of their weight is resting on that tissue. And that tissue is insensitive, so it makes for a very comfortable lens. This lens can be very intimidating to a practitioner that's new to it just because of the size and the rigid nature of this material. But in fact, for a patient, and if you've ever tried one on, these are very, very comfortable lenses. And the fluid inside the lens can feel very cooling and comfortable for a patient, especially who's been wearing a flat-fitting corneal GP lens. The lens optics with this type of modality are very well centered, and again I like to highlight the fact that this is a comfortable option for patients. So adaptation typically is not an issue with this type of lens modality. Now, adaptation is it can be problematic for corneal lenses. A disadvantage for scleral lenses can be lens handling. It can also be debris that can develop either on the front surface of the lens or inside the reservoir of the lens. But let's talk about diameter selection first. So sometimes it just depends on what you have in your office. It could be just whatever trial set you have, or if you have a favorite lab or manufacturer, it's whatever trial set that they offer as a scleral lens. And the other thing you have to think about is how you want to bear your lens. Again, a corneal scleral lens balances the weight on part of the cornea and the sclera. And if it's balanced solely on the sclera, it's a full scleral lens. So typically a corneal scleral lens will be a smaller diameter lens, so it's 14.5 or smaller on average. Again, there's some exceptions. And so you also want to pay attention to scleral obstacles. If a patient has a pinguecula, you might want to fit inside of it, you may want to lay on top of it, or you may want to go beyond it. Or if they have conjunctival irregularities, if they happen to have a symblepharon in the way, or if they happen to have surgically manipulated conjunctiva in cases of strabismus surgery or retinal surgery, you might want to fit a smaller lens to avoid some of these obstacles. And lastly, there's scleral asymmetry. The group out of the Pacific College of Optometry researched that the further you go from the limbus, you actually have more asymmetry to the sclera, and you might have to employ some toric or quad specific options to the back surface. So how do you evaluate scleral lenses? Basically, there's two philosophies. You can go inside out or outside in. I'm just going to describe the inside out philosophy. So you want to start with central corneal clearance. Again, I'm talking about scleral lenses that vault over the cornea. So you want to evaluate the cornea and the limbus to make sure that there's space between the lens and the cornea. You then want to evaluate how the lens bears on the sclera or the conjunctiva, so in the scleral landing zone. You're evaluating for compression, impingement, and edge lift. And lastly, you're looking for any scleral patterns. If the lens is a rotationally symmetric lens and has no significant pattern, you probably have a spherical surface. You may have a toric surface or an asymmetric surface that might require a quad-specific design. So central corneal clearance and limbal corneal clearance. Again, you can fill the lens with fluorescein and evaluate to see if there's any areas of contact, and you want to make sure that you're completely vaulting the cornea. Here you can see this poor patient has bearing over the graft-host junction on this transplant. So this needs to be lifted off on this patient. Whereas here we've got two areas of contact at the limbus as well as the apex of this cornea. So you can evaluate the corneal clearance using diffuse cobalt filter light with fluorescein in the well of the lens. You can create an optic section, and it's really easy to see the clearance with white light when you have fluorescein in the lens. And to determine how much corneal clearance, you'll typically know what the center thickness of your lens is, and you compare that with the amount of clearance you have between the cornea and the back surface of the lens. Now, patients that come in at the end of the day may not be coming in with fluorescein, so it's really important to learn how to evaluate corneal clearance without fluorescein. So here it's very important to identify the front surface, the back surface of the lens, the space, which is your clearance, and the front surface of your cornea. And this way you know you're completely vaulted. When you're looking at the scleral landing zone, you want to evaluate to make sure that there's no compression of the conjunctiva or blanching of those vessels that you can see here. You're looking at the major vessels are coursing through, but then these smaller vessels get impinged off underneath this area. So compression of the conjunctiva will cause this blanching effect. Impingement of the conjunctiva happens at the very edge of the lens. Now, typically I don't use vessels to determine this feature, but it just works out that this particular vessel you can see is actually pinched. So it's kind of bowed out. So when you're looking at 3D with a slit lamp, you actually do get the feeling that there's pinching occurring of the conjunctiva. If you miss it with the lens on, you'll know that the lens was impinging the conjunctiva if you take the lens off and put fluorescein in and see an arcuate staining area. That's suggesting that the lens was impinging into the conjunctiva. Edge lift can be the most uncomfortable feature immediately upon insertion. If a patient is aware of a scleral lens, typically it's edge lift, and so they'll just say, oh, I can feel it somewhere, and they may express that the lens is feeling tight when in fact there's some edge lift. And here there's excessive edge lift where you can see an air meniscus, whereas here if you put fluorescein in, you can see that the edge is highlighted, but typically you know, the edge lift is a lot easier to see if you put some fluorescein behind it. And lastly, there's scleral patterns. If you have excessive edge lift in one area, I tend to look exactly opposite. And here you can see a with the rule scleral ptericity, where you have fluorescein coming in from the top, fluorescein coming in from the bottom. But you can see it's pretty well aligned here and here, here and here. So I'm going to stop there talking about the different lens modalities and start bringing up how do you make decisions for when your irregular cornea patient shows up. So lens selection and fitting considerations. First and foremost, you have to put your whole patient's put the whole patient in front of you as the big picture. You have to determine what their lifestyle is, what their occupation is, their financial capability. Some of these lens modalities are a little more expensive than others, not only for the patient but also for you and your chair time. You also have to consider their recreational activities. You want a lens that's very stable if a patient's very active in sports. You also want to definitely consider their ocular health status. Just because the patient has an irregular cornea doesn't mean that they're not free of other corneal or ocular health conditions. They may have dry eye as well, or they may actually have glaucoma or other things that you need to treat. You want to pay attention to their corneal irregularity status, meaning does this condition progress, does it not progress? That may change your philosophy on how you fit. You also want to include them in the topics of what they've worn in the past. What is their past lens fitting history? What do they not want to explore again? What would they like to try again? And what would you like to try for them? What's always important is their motivation, because this can be a challenging modality, a challenging eye to fit. So you both have to make a plan together to ensure their visual rehabilitation and success. And lastly, they are handling these lenses, so it's important to also keep in mind their dexterity. Scleral lenses might be a little too challenging to apply for some patients, and some patients may not like the idea of using a soft lens because it's too soft and can fold on them. So ocular health considerations. We know that there's an association with atopy and eczema in your keratoconus patients, and here we have lid excoriation. So there's some things that need to be treated ahead of time before your patient is fit. As always, if you have any lid hygiene issues, you have to address that too, because you want to make sure that the patients are comfortable and not posing any risks for any future infections, as well as keeping their corneas clean and deposit-free as best as possible. You want to also make sure that there's you definitely do a thorough slit lamp evaluation, not only for ocular health considerations, but also pay attention to neovascularization. It's very important with the irregular cornea patient. And the reason I bring this up is because your endpoint treatment, if you cannot fit them with a contact lens, ends up being a corneal transplant. If they have corneal neovascularization, it poses a risk for them when they have a transplant, because now you have direct communication between their immune system and a new corneal transplant that could be sutured in here that could pose a risk for a graft rejection. So it's very, very important to document any findings of neovascularization and optimize which lens material you will use to provide the best, most oxygen delivery to that cornea. Lastly, there's also eye drops. Eye drops happens in patients with irregular corneas, in particular keratoconus, and the naturally occurring ectasias. So you have to bear in mind where they are in their post-eye drops healing phase before you might introduce one lens category to another. Again, here's a summary of the naturally occurring ectasias. So this is why I like to look at this, is because you want to determine at their age where they are in their progressive history. With keratoconus, again, it's self-limiting, but it is progressive. And so if they are young, you know that it might progress. And again, while cross-linking is not FDA approved yet, I think once it achieves its approval, there's likely, it may likely become the standard of care for patients with naturally occurring ectasias to halt the progressive nature of the ectasia. So it's something to keep in mind when you're managing this category of patients. So the other thing too is, if a patient comes in wearing a Corneal GP lens that's flat fitting, eventually that cornea is going to unmold. And so this becomes really important when you're fitting a custom soft lens as well as a scleral lens. You actually may have to stretch out your fitting appointments for that lens to that cornea to unmold. In particular, under a scleral lens, you might actually want to provide a little more vault before you finalize that lens, just to allow some more sagittal depth for that cornea to kind of bounce forward. And in, say, a custom soft fitting, you may not want to finalize your fit until you've fully evaluated their unmolding process. So it's always important to keep serial topographies and maintain serial topographies throughout their care. Just because you're fitting a lens, you're fitting their lens in a portion of time of their disease process. So you are forever managing their condition using contact lenses, and it's really important. This is a dynamic process of their condition and their fitting history, and sometimes fits do change because of the progressive nature of their conditions. And, you know, corneal GP lenses do fail. While they're a go-to lens for many of our patients with irregular corneas, you can see this poor patient is not even seeing through the lens because the optics are aligning over the apex of this cornea, and he's looking through the edge lift. And here you can see that the cornea is being very compromised from a flat-fitting lens. So indications for refitting into a different lens type. You've got contact lens intolerance, contact lens instability, poor optical performance, as you could see in that picture. You want to protect the corneal surface, so you don't want to have aggressive rubbing of the lens. You may want to eliminate piggyback or tandem systems, so they only have one lens per eye versus two lenses per eye. If they have an active lifestyle, as well as severe dry eye, there's options for them. So I'm just going to discuss a few case scenarios about, you know, how would we strategize fitting some of these types of patients. So here we have a central nipple cone, and for me my first go-to thought would actually be a corneal GP lens. And just because I know that it would provide centered optics for this patient, it would pretty much be a straightforward fit. Now, with the same topography between a 23-year-old and a 46-year-old, how does that change my thinking? So if the patient's 23, I know that this is central keratoconus. I know that keratoconus typically can progress, and say this patient is not going to have cross-linking. What does that mean? This patient will likely progress. So if I go ahead and fit this patient with a corneal GP now, chances are I'm going to have to keep refitting this patient as the disease progresses. How am I going to know that? So I'm going to know not only through topography, but also with the fluorescein pattern. So say, for instance, I start to fit this patient with my 3-point touch now. Next year the patient comes back and the lens has more apical bearing and corneal staining. So that to me is suggesting either the keratoconus has advanced or the lens has warped. So these are some things that I have to think about. Now if the patient's 46, the likelihood of this keratoconus advancing it becomes less. It becomes less of an issue. So I'd be more inclined on this patient to fit a corneal GP lens and not have to worry about refitting every year or two. I would probably just be replacing the lens for this patient. So in fact, I may go to this 23-year-old patient and fit them with a scleral lens, and I'll provide a little bit more space in the clearance just to allow that cornea to advance over time so that we don't have any corneal to scleral back surface lens contact, and the patient can have good wearing comfort and good visual outcomes even though the cornea tends to progress. So say for instance we have a 16-year-old boy. He's very active and he likes to play soccer, and he's been wearing soft toric lenses, but they're fluctuating on him, and topographies show advancing keratoconus. What would you do? So in this case, there's a whole bunch of options for him, and this is why I'm bringing up scenarios today, is because we covered all of the modalities, and there isn't always the right answer there's only one choice for your patient. There may be a group of choices for your patient, and you just have to be you know, aware of which might work best for the scenario. So in this case, if you decide to fit a corneal GP lens on a patient that's really active, then you have to worry about the lens stability. So sometimes with those corneal GPs, especially in an active child, they may pop out. Now, they're going to be visually successful because of the rigid optics. However, the stability might be a factor. So you could fit a custom soft lens for this patient, and then they already know how to handle a soft toric lens, so applying a custom soft lens won't be too challenging for them. You can fit your corneal GP corneal GP lens on this patient, and when they're being active outside, you can do what's called reverse piggybacking, where you put a soft lens over the corneal lens to kind of hold it in place while they're playing sports, and then they can take it out when they're done. You can definitely fit them with a scleral lens, and this would also provide a layer of protection for the patient that's active too. And so there's a whole host of options for this patient, and you just have to strategize with this patient, with the patient's parents, what financial contribution do they want to make? Is the patient willing to use a reverse piggyback system, or do they want to stay in a soft lens just because it's easier? So here we have another scenario where, is it a low cone? Is it emerging pellucid marginal degeneration? The age is 35. If this patient shows up in your chair and you've never seen the patient before, you won't know the answer to that. And so this can be really challenging from a progressive nature. And this is why I was saying in the beginning of our presentation why sometimes it's a spectrum, because some of the clinical features of each condition can be ambiguous and they might merge together, and this is one of those situations. In this case, if I was to fit a corneal GP lens, I would fit a larger diameter corneal GP, an intralimbal GP lens. If the patient was active, I would actually consider a custom soft lens for the patient as well as a scleral lens. Here's another scenario. We have a patient who has long-standing stable keratoconus who's been wearing corneal GP lenses but recently became uncomfortable. Both eyes are always dry. She's wearing punctal plugs. She's using topical cyclosporine, and she works on a computer. What do you do? Well, this patient to me is used to GP vision. She has a dry eye component. For me, I think that a scleral lens is definitely an option for this patient. And another unique feature of the new scleral lenses that are out on the market today is that there's multifocal options for your patient. So since she works on a computer, that might be an option for her to consider as well. So having a lens that has a supplemental artificial tears or saline solution in the lens that also can lubricate the cornea while the lens is worn, I think that this is a win-win for this type of patient. Now this is a 5-year-old boy. Actually, this is a real patient that presented to me, keratoglobus and blue sclera, hypermobile joints. And for me, this is a patient, again, that I fit with the scleral lens. And the reason being with the scleral was because it provided protection. Now, the nice thing about this situation is he has congenital keratoglobus, so it's not a progressive condition, so I don't have to be that mindful of giving more room in the clearance for it to progress. Of course, I always have to monitor that, especially in a child, because the lens may sink into more of a squishy conjunctiva. But again, you have another layer of protection on a child that's probably very active. This is a keratoglobus cornea, and you can see this lens was 200 microns thick, and if you compare the cornea to that, we're dealing with a very thin cornea. So having a scleral lens can be protective for these types of patients and helpful for the long-term success. So for this patient, I prescribed a scleral lens as well as polycarbonate glasses for over top for an additional layer of protection. And the reason being is this is another keratoglobus child that I have fit, and he had a decimase rupture just by an accident on the playground, and this is the original rupture here, and this right here is actually his decimase membrane that's floating in the anterior chamber. So again, I want as many layers of protection as possible for these fragile corneas. Lastly, we have an RK patient, and he's got fluctuating vision throughout the day, multiple spectacles. And in this type of patient, again, I think all three modalities, having a custom soft or having a scleral or a corneal GP, are all very good indications for you to consider fitting this type of patient. So lastly, I just want to bring up some educational resources that are available from Bausch & Lomb. If you go to the fitboston.com website, you'll be able to go visit the eye care professional section, and there you'll find the Scleral Lens Fitting Guide. The Scleral Lens Fitting Guide is an extensive literature search based on input from an international advisory board. It describes anatomy, scleral shape, scleral lens design, and fitting approaches, as well as managing scleral lens wear, and it's available in many translated options. There's also the Keratoconus Fitting Guide, which is a comprehensive overview of keratoconus that includes epidemiology, the classification, lens designs, modalities, and management. Again, this is also included in many different translated versions, and this was written by the Center for Contact Lens Research at the Waterloo Optometry School. There's also the Boston Materials and Solutions Product Guide. This product guide has an overview of GP materials, which materials are best for what type of lens designs, and it describes which ones have UV absorbing capability, what the decays are, the lens wetting angles, modulus, and it also describes Boston solutions as well. There's video resources, so for those of you that are new to fitting scleral lenses, there's the Scleral Lens series, and they're just 3-minute videos that go into, the first video talks about scleral lens central clearance, so the vaulting of the cornea with the lens, and it has live slit lamp videos of evaluating the central clearance with an optic section. There's the compression and impingement video that describes the scleral landing zone and how to evaluate it. There's a third video that was recently uploaded, and that's describing limbal clearance and how to troubleshoot limbal clearance. There's also a link to the sclerallens.org website, and it's an application and removal video that's so well done, that's helpful for not only practitioners but for patients. And it demonstrates applying the lens without a plunger and removing with and without a plunger. It also features scleral lens care as well. For those of you that are interested in learning about Kerasoft IC, there's the kerasoftic.com website that talks about the lens itself, as well as there's also, if you've been fitting this lens, there's a Morocco VA app which allows you to fit the lens, and it documents your fitting as you go and troubleshooting the lens itself. And using this app, you can order the lens directly through the lab. And so it's a helpful tool for fitting that lens modality.